Any questions? But about stress, oxidative stress, after first slide, nothing. What do you think? And correlation with hyperandrogenism?
I think, again, as I mentioned, of course, hirsutism for women is a distressful phenomenon. Not getting pregnant is a stressful phenomenon. So I'm not surprised that the level of stress is increased. And all the studies and all the meta-analysis show the same. But also, on the other hand, it's clear to realize that it's only modestly increased. And normally, most papers say well within the normal range. So on average, it may be slightly higher, and it's significant. But I'm not sure whether it's clinically relevant at this stage, because it's so understandable, let alone that it is related to the pathophysiology compared to the patients Sarah focuses on. There is a clear link. I'm not sure in PCOS whether that's the case. Sarah, what do you think?
I think it might protect from stress. I call it hypothalamus robustus.
Yes. You would expect under these clinical conditions that stress levels would be further increased? Is that what you're saying?
No, I think PCOS protects from stress. It's nice to have a little androgen around.
Okay.
I call it hypothalamus robustus. I don't think they get as stressed. Oxidative stress.
Because we see when we give
yeah.
But
in the cell,
but cortisol is oxidative stress too. Yeah?
Yeah, the increase of, no.
I think Bart is right, we're missing something. We don't know enough.
Go ahead, Tommy. You mentioned how heterogeneous is the PCOS group. And I'm wondering if there is any effort in separating PCOS patients who have insulin resistance and obesity versus those who don't, whose pathophysiologic process may not be related at all to the metabolic dysfunction, but may be related to hypothalamic pituitary dysfunction with high LH and low FSH. Would their cardiovascular risk differ from those patients who have insulin resistance, those patients who have more obesity, etc.?
I think in 5 to 10 years we can answer those questions, because there you need standardized phenotyping, which now many people do, and then do long-term follow-up, and then you can see which initial screening parameters correlate to outcomes. We know now at least that hyperandrogenemia at a young age is the most important determinant for cardiometabolic surrogate abnormalities, if you wish. And of course, that usually coincides with obesity. So that's why it's good if you are very inclusive, then you can make all kinds of subgroups later on and try to answer the questions you were asking, but now we can't.
Bart, it's possible that I'm going to preempt Bill Crowley here, but vis-a-vis his talk this morning, I guess if you're looking for something, or there's something missing, what did the GWAS tell us? And your colleagues have done a pretty nice job in that area. Is there insights that you can sort of share?
Yeah. Now, I think the reality today is that most of the GWAS data that are available are not published yet, so only a few. And what they're doing now, and also they're underpowered. Most studies, they have about 800, 1,000 women, PCOS women in the GWAS studies, which is insufficient to come with firm conclusions. So that's why that made everybody realize we got to get our act together. And that's what they're doing now. So within the next year, you will see, I think, more definitive papers coming with thousands and thousands of women included.
To just support exactly what was said here, you have a disease that's a complex trait genetic disease. And we all try to make sense out of it, like insulin resistance, non-insulin resistance, et cetera. And what we fail to recognize is that in the domain of complex trait genetics, there is a huge precedent and confirmation and validation now of things like type 2 diabetes, schizophrenia, autism, inflammatory bowel disease, multiple sclerosis, et cetera, et cetera, et cetera, where the same things have been encountered. Lots of clinical heterogeneity, lots of efforts to try to subdivide in hundreds and sometimes even thousands of patients, all to no avail. And only when groups get together and start to pool their data and start to appreciate the numbers it takes to really see the genetic architecture under, do you realize how futile the effort has been, how much time and money has been wasted. And I'll give you a good example. Nobody would go around and say, gee, if we could only subcategorize the type 2 diabetics, you know, there's some that have high insulin, some have low insulin, some are obese, some are not. Nobody would consider doing that now. But they did 5,000 patients, no genetic structure. 10,000 patients, no genetic structure. 15,000 patients, 1 or 2 genes, PPAR gamma being the first one that appears. And now they're at 185,000 patients, 185,000 controls, and now they have 90 genes. Schizophrenia, 15,000. Inflammatory bowel disease, 15,000. Autism, 20,000. This is what it takes for one simple reason. There's hundreds of genes involved. So the efforts which we stopped in the 90s trying to phenotype because we couldn't make any sense out of anything we did. There was always confounding factors here. And it's a complex trait, genetics. And I think your answer is exactly right, Bart, that once we get all these together and now take the genotype and go back and see what the phenotype is, so phenotyping on a genotype basis, now you're going to start to see some heterogeneity. And a recent example of that, which is striking, is the HNF4 alpha locus in type 2 diabetes. It turns out to impart a very small relative risk ratio of like 1.1, 1.5. But when you see it on a Hispanic background, it's 40% of the Hispanics have this mutation, and it has a relative risk ratio of like 1.5, 1.6. And they're starting to look homogeneous because they've got an ethnic background, and it's almost like a Mendelian disease now, and you can subphenotype. So I think your answer is right, except it may not take 1,000, although the Han...
No, I think we are, collectively it's about 5,000 now, but if I hear you, that may be even at a lower limit.
Well, the good news is the Han study turned up to loci that everybody's validated now. DENT1 and THADA have been validated in other studies. Many other ones have not because they don't bear up on replication. But I think you're right. It's got to be somewhere...
It's numbers and standardized phenotyping, because hyperandrogenemia by itself is not an easy diagnosis. Exactly. It's an easy word, but it's not an easy diagnosis.
If you think about type 2 diabetes, the only standard phenotyping was an elevated blood sugar. But it's a type 2 error.
Keep it simple.
You just have to have lots of patients. The looser the phenotype, the more patients you need. The more stringent the phenotype, the less you need.
Thank you.